Throughout these lectures on hematology, we have been discussing anemias. We started off by discussing the various types of anemias, and then we classified the anemias according to their MCVs as the normocytic, microcytic, or macrocytic anemias. Then later on, we reclassified the anemias into either the anemias of production or the anemias of destruction. The anemias of destruction can also be referred to as the hemolytic anemias, and then we discussed them as part of inherited or acquired disorders. Now, the other term as the anemia of production can also be classified or can also be presented under the umbrella of the term as the bone marrow failure syndromes. Because in the anemia of production, there is something inside the bone marrow that is going wrong and preventing the normal functioning. These types of anemias are generally normocytic, normochromic, but they can also be macrocytic if there are especially B12 or folate deficiencies or other minerals deficiencies. So our topic of discussion today are the bone marrow failure syndromes and what are the major topics that come under this umbrella. The bone marrow failure syndromes can be classified into four major groups. The first one and the most common are the aplastic anemias. Then there are some myelodysplastic syndrome. Then there is pure red cell aplasia. And finally, there is myelophysis for the matter of completion. In this lecture, we are going to talk about the aplastic anemia and the pure red cell aplasia. And then further on in the second part of our lecture on the bone marrow failure syndromes, we are going to discuss myelodysplastic syndrome and myelophysis in great detail. In all the bone marrow failure syndromes, there is one common feature, which is pancytopenia. Pancytopenia, pan means all. So pancytopenia basically means that there is a generalized defect which affects all the blood cell lineages, be it the platelets, the WBCs, or the red blood cells. So there is going to be anemia, there is going to be thrombocytopenia, and there is going to be leukopenia or decreased white blood cell count. And then they have their own manifestations. So pancytopenia can generally be defined as a combination of disorders in which there is a deficient cell lineage in all the types of hematopoietic cells. So the RBCs will be low, which will lead to anemia. Then there will be leukopenia because of decreased WBC count, and thrombocytopenia because of the decreased platelet count. Now let's talk about the differential diagnosis of pancytopenia. We basically differentiate the various patients presenting with pancytopenia on the basis of the bone marrow picture. So if we have a hypocellular bone marrow in which there is a decreased count and basically the bone marrow is replaced by fat and other cells, then the major disorders which we can think of are the aplastic anemias, especially the acquired type, or it can be a constitutional aplastic anemia if it presents at a very young age in an infant or in a young child. And certain types of myelodysplasias also present with the hypocellular bone marrow. Some rare aleukemic leukemias, they are very rare disorders. certain types of acute lymphoid leukemias or ALL, they also have a bone marrow hypocellularity. And then certain lymphomas of the bone marrow, they can also present with a hypocellular bone marrow. If on the other hand, with the pancytopenia, the cellular count is well and there is a normal cellular count, and we have a cellular bone marrow picture, then the primary bone marrow diseases are the ones which we concentrate on. Specifically, the important ones are the myelodysplasias. As you can see that the myelodysplasias generally present with a cellular bone marrow, but in certain rare types, they can also present as a hypocellular bone marrow. Then a condition which we discussed in our previous lecture, paroxysmal nocturnal hemoglobinuria, it is also a primary bone marrow disease, and it also presents with pancytopenia. Certain types of myelofibrosis in which the bone marrow is replaced by fibrous tissues. And then again, certain rare aleukemic leukemias, they also have a cellular bone marrow picture along with pancytopenia. Myelophysis, which we are going to talk about in the second part of our lecture, is also has also the features of a cellular bone marrow along with a pancytopenic picture. Certain types of bone marrow lymphomas. So as you can say that the lymphomas, which are the tumors of the lymphoid tissue, they have a mixed picture. Some of them present with a hypocellular bone marrow, some have a cellularity. So it is important to differentiate these two types on the basis of the bone marrow presentation. And then hairy cell leukemia, which is caused by the HTLV virus, also is a primary bone marrow disease, and it also presents with pancytopenia. Now, in certain patients, the bone marrow is hypocellular, but the patient might have cytopenia, or the patient may have or may not have cytopenias. So it can involve a certain one type of a cell lineage rather than affecting all the cell lineages. These are certain conditions. Specifically, the important ones to remember are the Q fever. Then there is a Legionnaires' disease, which is a bacterial disease, as we all know. It can have a pancytopenic picture with a hypocellular bone marrow and may have or may not have cytopenias. Then anorexia nervosa, or starvation, which is basically a psychological disorder, can also present with a hypocellular bone marrow. And finally, mycobacterium infection, specifically the Mycobacterium tuberculosis, when it involves the bone marrow, or certain types of rare mycobacterial diseases like the Mycobacterium avium intracellular, especially in the context of patients with decreased immune system like HIV patients. They have also a hypocellular bone marrow picture. So whenever we have pancytopenia on the peripheral blood film, it is important to do a bone marrow exam so that we can differentially classify the patients on the basis of their bone marrow picture. All right, let's move on to our main topic of discussion today, which is aplastic anemia. Now, aplastic anemia in simple terms can be defined as pancytopenia in which the bone marrow is basically replaced by the fibrofatty tissues. As you can see, this is a picture of a bone marrow exam of a patient with aplastic anemias. Generally, in a normal person with bone marrow, there are a lot of cells in the bone marrow. Around 30 to 70% of the bone marrow is composed of the various types of cells. But here you can see that the whole bone marrow is basically replaced by white fat cells. These white molecules which you are seeing here, globules, these are fat globules, and they are very rare in dispersed WBCs somewhat here. So aplastic anemia is basically a disorder of the bone marrow in which there is some problem in the bone marrow that leads to the destruction of all the cell lineages. So the patient will have the signs and symptoms of the deficiency of all the types of cells, be it the platelets, the WBCs, and the red blood cells. So aplastic anemia can simply be defined as a pancytopenia in which the bone marrow is basically replaced by fibrofatty tissues. Let's talk about the etiology of aplastic anemias. There are a lot of conditions, a varied variety of conditions that can cause aplastic anemia. Generally, the acquired variety of aplastic anemia, which generally occurs in young adults ranging from 20 to 40 years old, acquired type is the more common type of the aplastic anemias. In certain patients which have certain genetic problems or certain chromosomal abnormalities, we might have some inherited aplastic anemia disorders, which we are going to talk about in a minute. But for the majority, the aplastic anemia is generally an acquired disorder. And what are the different types of conditions that can lead to aplastic anemias? Now, aplastic anemia can either be a secondary problem to any underlying problem, or it can be a primary disorder. The primary type is the idiopathic type, in which we, after ruling out all these various types of disorders with the help of a good history and a physical exam, if we cannot arrive at a secondary as a primary cause that has led to the aplastic anemia secondarily, then we generally classify the aplastic anemia as an idiopathic disorder or as a primary acquired aplastic anemia without any underlying cause. So if we talk about aplastic anemias being a secondary disorder, then there are various types of conditions that can cause this destruction of the bone marrow. The most important ones are the certain types of radiation, specifically in patients undergoing intensive chemotherapy or intensive radiotherapy. These patients present with with problems with the bone marrow, as the bone marrow is very radiosensitive because it is a very rapidly dividing tissue. So any patient who has a prolonged exposure to the radiotherapy, or someone who is working in some nuclear plants or some hospital staff which are working with radiations all the time, like the radiologists or the technicians of the radiology department, these patients are prone to developing aplastic anemias over a period of time, because when there is a cumulative effect of radiations with increasing with passing years, and that in some patients can lead to bone marrow abnormalities. It can also lead to certain types of leukemias and lymphomas. So radiation is one common type. Then there are certain types of drugs and chemicals. The important drugs also are the ones which are cytotoxic to the bone marrow, specifically the anti-cancer drugs, the tumor suppressive agents like cyclophosphamide and various types of anti-cancer or anti-tumor drugs. Then certain rare antibiotics like the sulfonamides can also cause these problems. Drugs and chemicals either directly damage the bone marrow by their regular effects. This is more common for the cytotoxic drugs or the anti-cancer drugs which are used in chemotherapies. Or the aplastic anemia can be an idiosyncratic reaction, which generally means that it is an allergic reaction to certain types of drugs. Now, the regular effects are generally cumulative, they occur over a period of years. But the idiosyncratic reaction can occur on the first exposure to the drug, and these are very rare. For example, in certain types of NSAIDs or non-steroidal anti-inflammatory drugs, 1 in a million patient might be sensitive to one of these drugs. And if you give that patient that drug, that patient certainly develops all the types of heaving, chest syndrome, or various types of rash because of an idiosyncratic reaction. And it can be very mild, and it can also be very severe. And the severe forms can damage the bone marrow in the long run and can lead to aplastic anemias. One important chemical here to mention is the benzene. Benzene was historically used in various types of industries as a solvent, and it has been very potently described, or in various types of studies it has been established that benzene exposure is related to the development of aplastic anemias over a period of years. So benzene is an important chemical to keep in mind when we are talking about the different types of chemicals causing aplastic anemia. Now, certain types of infections, specifically the viruses which can target the bone marrow, the important ones here are the Epstein-Barr virus or the EBV. Then different types of hepatitis. It is important to understand two things regarding the hepatitis here. One is that this is a seronegative hepatitis. By seronegative, I mean that it is not hepatitis A, B, or C. It is some other type of infection leading to hepatitis that causes the aplastic anemia. Hepatitis A, B, C generally do not develop. Hepatitis A, B, C patients generally do not develop aplastic anemias. The second important thing is that hepatitis can be an initial presenting complaint of the patients with aplastic anemias. In certain types of patient, for example, in about 6 to 10% of types of aplastic anemias, the patient presented with hepatitis, and later on that seronegative hepatitis basically transformed it into a type of aplastic anemia. So these 2 points are important to keep in mind when we talk about the hepatitis. Then there is parvovirus B19 infection. This virus generally targets the infants and causes a fifth disease, which we generally mention as the fifth disease, which is part of the different types of rashes that the infants can have. In adults, it generally causes arthritis-like syndromes. But in certain types of patients, specifically who have hemolytic anemias, the parvovirus B19 can target the blood cell lineages and can cause different types of varied presentations of aplastic anemia. Specifically, it causes pure red cell aplasia in patients who are already deficient with their bone marrow, or who have, for example, hemolytic anemias. It can trigger that increased hemolysis in patients, or it can cause a pure red cell aplasia in these patients as well. So parvovirus B19 is one of the important viruses to remember in the context of the hematopoietic disorders. HIV patients who have full-blown AIDS picture, they can have development of aplastic anemias because of immunodeficiency. Now, certain types of immune diseases can secondarily lead to aplastic anemia. The important ones are the eosinophilic fasciitis. It is a rare disorder in which there is a inflammation of the underlying fascia, and because of certain because of certain allergic reaction or certain type of various types of eosinophils that affect this underlying fascia, and it is not very common in normal practice, but you should be familiar with the term of eosinophilic fasciitis causing aplastic anemia. Certain types of hyperimmunoglobulin, for example, hyper IgM or IgG, they can cause aplastic anemia. Then certain types of lymphocytosis, like the large granular lymphocytosis, thymoma, if the some patients who have a thymoma or a thymic carcinoma, they also have been reported to have some problems with the bone marrow, specifically the aplastic anemia. So if you have a patient with aplastic anemia and you are not able to find out the underlying cause, the more common ones, it is important to look at investigate for thymoma. You might do some radiographic tests like chest X-ray or other investigations, for example, the CT or the MRI, to look for a mass in the of the thymus. And then in transplant patients, graft versus host disease, when there is transplant rejection, can lead to aplastic anemia or the bone marrow problems as well. Paroxysmal nocturnal hemoglobinuria, which we talked about when we were talking about the hemolytic anemias, it can also co-present with aplastic anemia, or it can either these two disorders, the PNH or aplastic anemia, can either co-present or one can lead to another, either aplastic anemia later on leading to PNH, or PNH in some patients later on leading to the aplastic anemia. So if we have someone with PNH over a long period of time and the symptoms are not improving with regular treatment, you should look to investigate for aplastic anemias as well. Very rarely someone who becomes pregnant can develop aplastic anemia during the pregnancy, and it goes away when the pregnancy is over. And it can also develop in patients having an abortion. So this is very rare, but this can also be a secondary cause of aplastic anemia. And if we are not able to find any of these causes after investigation, then we generally classify that as an idiopathic or primary acquired aplastic anemia. And the most common type of aplastic anemia is the idiopathic type, in which we are not able to find any underlying cause. Certain types of inherited disorders can also lead to aplastic anemias. Now, this is a very long list, and you don't need to remember all of them. The important ones to remember or keep in mind are the Fanconi anemia. It is one type of disorder in which there is aplastic anemia. All of these present in young adults, or so in the infants, the inherited types, or in the young kids, 1 or 2 years old. In Fanconi anemia, along with the aplastic anemia, there is certain problem with the digits or the musculoskeletal system. The other different disorders, or the rare terminologies, are the dyskeratosis congenita, then Schwann-Diamond syndrome, then there is reticular dysgenesis, megakaryocytic thrombocytopenia, and certain different types of familial aplastic anemias, pre-leukemia, and non-hematologic syndromes. So this is a long list of inherited aplastic anemias, but if you have to remember one, then you should just remember the Fanconi anemias and its association with affecting the digits and the musculoskeletal system. So this flowchart gives you a very good differentiation or classification of aplastic anemia based on the etiologies. Now let's talk about the pathophysiology, or what is the underlying process that has led to this aplastic anemia development. First, let's look at a normal bone marrow biopsy. Here you can see this is a normal bone marrow picture, and this is a normal bone marrow aspirate. You can see that the bone marrow is basically filled up with all the types of cells, and when you perform a bone marrow smear, you can have all the various types of WBCs, white blood cells, and red blood cells, and the platelets. Generally, 30 to 70% of the bone marrow is covered up by the cells. Now, in someone with aplastic anemia, if you can compare the both pictures, this is a normal biopsy and this is a biopsy of a patient with aplastic anemia. All the cells have basically been replaced by this white globules, which are fat globules. And there is very rare interdispersed cells between these fat globules. And when we perform an aspirate, again, you can see that the large majority of the bone marrow has been replaced by fats, and there are some very rare interdispersed cells in between those fat globules. What is the pathophysiology? What are the basic underlying process that has led to this development? If we talk about going into the basics and talk about a stem cell, then there is certain type of environmental insult, for example, viruses, drugs, or certain other types of disorders, like in certain immune problems, that has caused an insult to the stem cell or damaged the stem cell. Then the stem cell is basically genetically altered and has lost its normal function, and it can go on two basic pathways. Either it can become a target for the immune system by expressing the new antigens and inviting the various types of immune cells to target it, or it can genetically be modified into a cell which has a reduced proliferative and differentiative capacity. Now, this reduced capacity eventually leads to the aplasia of the bone marrow and leads to interferes with the normal functioning. And the bone marrow cell lineages can go down of all types, like the WBCs, white blood cells, or the platelets. Immunologically, if the cell expresses the new antigens, then it becomes the target of the various types of T cells, like the cytotoxic T cells. They release different cytokines like interferons, the TNF alpha. They target those types of cells which have expressed these antigens, and then they also, after an immunological reaction, can lead to myeloaplasia. So, simplifying this diagram is a very oversimplification of the process underlying pathophysiology. There is a certain environmental insult or certain types of trigger that has led to the development of aplastic anemia, either immunologically or either because the cell have lost their ability to proliferate and differentiate. Now, when we have a patient presenting with pancytopenia, we basically go through the same routine. It is very important to have a good history of the patient, followed by a physical exam and then the relevant lab tests. What are the important questions to ask in the history of the patient? Number one, the patient with aplastic anemia, the first sign with the patient, the symptom with the patient generally presents are certain types of petechiae or blood oozing from the various parts. This is because of thrombocytopenia, and majority of the patients, thrombocytopenia is the first presenting complaint of patients with aplastic anemia. The patient might present with a bruise or with different types of petechiae, and otherwise the patient will be fine. There will be no fever, no infection, and over a period of time, the patient gradually goes down. When the WBC count goes down, the patient might develop some infection or fever, or when the RBC count goes down, the patient might have signs and symptoms of fatigue or anemia. So it is important to inquire information about the easy bruising, any oozing from the gums or the nosebleed or heavy menstrual flow or the petechiae, because this is generally a presenting complaint of patients with aplastic anemia initially. It is also important to inquire about the systemic complaints, for example, weight loss. This is important in the context of certain types of disorders leading to aplastic anemias, like systemic lupus erythematosus or different types of other immunological disorders. So we generally inquire the patient on a whole and look for the various types of abnormalities outside of the hematological system as well. Prior drug use, the chemical exposure, and certain types of preceding viral illnesses, as we saw in the etiology of the aplastic anemias, it is also important to inquire about certain prior illnesses or certain prior drug exposure. Then family history is also very important, specifically of hematological abnormalities, hematological disease or the blood abnormalities. And especially if the patient is very young or presenting as an infant, then this can be a hematological genetic problem as well. So after a good and targeted history, we move on to the physical examination. As I told you, the petechiae are generally the initial presentation of patients presenting with aplastic anemia. The petechiae can also accumulate into ecchymosis, which are basically groups of various petechiae. The blood hemorrhage can also involve the eye and can present as a retinal hemorrhage, so there might be certain vision problems. And when you go to an ophthalmologist, you might have retinal hemorrhages on the examination. Along with that, there can be bleeding from various orifices. For example, in females, it can be bleeding from cervical os. It can also be present as a manifestation, for example, with increased menses or menorrhagia. Or there can be blood in stools, which can basically present as hematochezia as well, or profuse bleeding as well. And as I said, that aplastic anemia generally is a disorder involving the young patient. So any young patient presenting with blood and stool, you should evaluate or keep in mind that aplastic anemia can also be in the differential diagnosis. Because generally when we have an older patient presenting with blood in the stools, we basically, the number one thing to rule out is the colorectal carcinoma, specifically after 50 years of age. But in the younger patients, if we have these bleeding abnormalities and these are unexplained, aplastic anemia should be in your differential diagnosis. One important differentiating point and very important specifically regards to the physical examination is the absence of splenomegaly in patients with aplastic anemia. Aplastic anemic patients generally do not develop splenomegaly. As you saw in the case study when we talked about a patient, Florence, who is a 24-year-old female, she had absence of hepatosplenomegaly along with bruising or epistaxis. So that clinical picture perfectly fits with aplastic anemia. Then, if we have an inherited disorder, some young infant presenting with pancytopenias, the different types, for example, if someone has Fanconi anemia, then they have certain digits problem, like the peculiar nails, the nail swelling can be there, or certain abnormalities with the digits or the whole musculoskeletal system. Similarly, in patients with disc keratosis congenita, there are certain gum abnormalities or different malabnormalities of the teeth or the different type of oral cavity problems. And then there are certain telomerase defects, which are basically telomerase are the end portion of the DNA segments, which can have certain abnormalities, the different mutations or breakage that can lead to development of congenital types of or the inherited types of aplastic anemias. Now, after history and physical exam, let's look at what are the different types of labs which we have to perform. On a peripheral blood film, we might have the large erythrocytes, which are basically the primitive cells. There will be a decreased count of the normals or the mature cells and an increase in the immature cells. So the platelets shape might be abnormal. There might be variations in their size and shape. The granulocytes might be decreased. There is an increased MCV generally, normal to an increased MCV. The reticulocyte count is low because the bone marrow is unable to produce newer cells to compensate for the decrease in the cell lineage. Then there is a less number of lymphocytes as well, and the immature forms are primarily evident on the peripheral blood film rather than the mature types of cells. The nucleated RBCs, which are the primitive RBCs, so we are basically going to see large cells which has raised the MCV count, and the primitive types of cells which have certain types of nuclei, like the RBCs. A mature RBC does not have a nucleus, so nucleated RBCs or immature myeloid forms and immature types of platelets and lymphocytes will be evident in the peripheral blood film. Then it is very important to do a bone marrow exam, and that is the basically the definitive way to diagnose aplastic anemia. The bone marrow will have aplasia, in which there is a decrease, it is replacement by the fibrofatty tissue. There can be certain sparse megaloblasts, a very large size of the megaloblasts. The bone marrow will have a hypocellular picture, as I showed you in the initial slides. And then the megakaryocyte count, along with the other types of counts, the WBCs and the red blood cells, it will also be decreased. And if the problem causing aplastic anemia is certain types of granulomatous disorders like sarcoidosis or tuberculosis, then these patients can also have granuloma formation, and it gives us a good clue to evaluate the granulomatous diseases, specifically if we have a granulomatous picture of the bone marrow. If we are suspecting a chromosomal disorder, specifically in the young child, then there are certain types of ancillary studies that we have to perform. The nucleotide sequencing, looking for chromosomal breakages or in the peripheral blood film. There can either be a telomerase length disorder in which the telomerase are shortened, or there is a certain types of mutations in the telomerase. Again, we might do chromosomal studies of the bone marrow to look for these abnormalities, and these are specifically evident in patients with MDS or myelodysplastic syndrome. Flow cytometry is one important study to do, specifically if we are suspecting PNH, as we talked about in our discussion on the PNH. Then certain types of serological studies looking for antibodies against the viruses, specifically the viral infections like the Epstein-Barr or the HIV virus. They are important to do if we are suspecting these as the cause of aplastic anemia. Computerized tomography or CT scan can be important, specifically if we are talking about looking to evaluate the spleen size, or if we're looking for a thymoma as well. And certain types of MRIs can also help us distinguish aplasia from the myelodysplastic syndromes. We are going to talk about it when we talk about the myelodysplastic syndromes. So these are the major investigations which we have to perform in patients to arrive at a differential diagnosis and finally definitively diagnose patients with aplastic anemia and then look for the cause of aplastic anemia. The overall diagnosis basically based on the family history of the patient, if there is a hematological history in the patient's parents, or if there is certain abnormal blood cell count, for example, the pancytopenias, which lead to the diagnosis of aplastic anemia, and finally the presence of associated physical anomalies, specifically in young adults, which might have Fanconi anemia or dyskeratosis congenita. These type of associated physical anomalies give us an insight to arrive at a diagnosis, the cause of the aplastic anemia. Now, what are the various treatment options which we have for the patient with aplastic anemia? The treatment is generally, definitive treatment is the bone marrow replacement with hematopoietic stem cell transplantation. And if we can find a suitable donor, then these patients can lead a perfectly normal life after the hematopoietic stem cell transplantation. Because generally, this is a disease of the young patient and they are medically fit generally if they have an idiopathic disorder. Immunosuppression can be tried specifically. It can be in the oral form, like the antithymocyte globulin in combination with cyclosporin, or the other types of anti-cancer drugs like the cyclophosphamide. And if we are looking for an IV therapy, might use horse antithymocyte globulin. It can be combined with methylprednisolone or the steroids. Glucocorticoid therapy can also be tried on its own for immunosuppression. The other therapies which have been tried and have mixed successes are the androgens therapy, for example, the sex hormone replacement, sex hormone therapy, or thrombopoietin mimetics can be given to stimulate the thrombocytes to produce the platelets. And otherwise, we have to symptomatically manage the patient with supportive care, manage the presentations. For example, if someone is having an infection, presenting, we can give them, if there's a fungal infection, we might try antifungals. Antibacterials can be tried for bacterial infections. If the patient's blood count, hemoglobin goes too low, we might transfuse the patient with RBCs. Then we have to look for RBC transfusion or the granulocyte transfusion, and also look for the chelation therapy to avoid the iron overload. Platelets can be transfused if we have thrombocytopenia as well. So these are generally the hallmarks of the treatment. Generally, it is a supportive care, and if we can find a suitable donor, then the curative treatment is the hematopoietic stem cell transplantation. Now let's briefly talk about a disorder called pure red cell aplasia. As the name itself shows, that it is generally an aplasia which generally targets the erythrocytes or the RBCs. So the other cell lineages are generally normal. The WBC count or the platelet count is generally fine, but the RBC count is generally decreased. What happens in pure red cell aplasia is that certain types of environmental insults, there can be certain viruses like the parvovirus B19, which infects patients with hematological problems, and it can target the one precursor of cells like the erythroid precursors, leading to the pure red cell aplasia. The other various types of disorders that can lead to pure red cell aplasias are, it is generally self-limited on the whole, and it goes away after a couple of weeks of symptomatic treatment, which we generally classify under the term as transient erythroblastopenia or transient aplastic crisis of hemolysis. This generally transient aplastic crisis is basically because of the parvovirus B19 infection. It can also occur in a fetus, and that has led to the non-immune hydrops fetalis, or the loss of the fetus, non-immune type of hydrops fetalis. It can be a hereditary pure red cell aplasia, a very rare disorder, but it can be a hereditary problem, which is generally classified as a congenital pure red cell aplasia. In the acquired types of pure red cell aplasia, viruses are the major types, and they can also occur secondary to certain types of immunological or certain types of chronic infections. Like if someone has a cancer, various types of lymphomas or leukemias, then they can, because of a problem with the hematological system, they can have a pure red cell aplasia in a self-limiting form. Thymoma, as when we talked about the aplastic anemias, thymomas can also present with acquired pure red cell aplasia apart from the aplastic anemia. Lymphoid malignancies, leukemic malignancies are the most important ones. And if there are certain paraneoplastic tumors infecting the bone marrow, for example, from the breast or the colon or from the liver, they can also lead to the pure red cell aplasia. Connective tissue disorders with immunological abnormalities, the important ones or the most common are the systemic lupus erythematosus or SLE. Juvenile rheumatoid arthritis in young child can co-present with the RBC aplasia, or rheumatoid arthritis in an adult can also present with an RBC aplasia. And finally, multiple endocrine gland insufficiency like the MEN syndromes, they can also have a red cell aplasia picture. So this exhaustive list is basically the major types of disorders that have aplastic anemias. Apart from them, certain types of infections can also lead to aplastic anemia. Specifically, the important ones, as I talked about, as viruses, are the B19 infection. This can be a persistent infection which can present chronically along with arthritis-like symptoms in a young adult. Hepatitis, the seronegative hepatitis, as we talked in aplastic anemia, they can also lead to pure red cell aplasias. So as you can see that there is an overlap of a large number of disorders which can either present with RBC aplasia, red cell aplasia, or can present either with a aplastic anemia. Adult T-cell leukemia virus, which leads to hairy leukemia, can also have this presentation, and Epstein-Barr virus, as we talked about in aplastic anemia, can also lead to an RBC aplasia. Rarely, pregnancy in patients and females who are pregnant, they can have a pure red cell aplasia, and it goes away after the pregnancy is over. Certain types of drugs like the phenytoin, the anticonvulsant drug, or azathioprine, anti-tumor drugs, chloramphenicol, the historic antibiotic, which is not used now, it has been very seriously linked to the abnormalities of the bone marrow, can cause aplastic anemia or can cause RBC aplasia. Procainamide and isoniazid, which is an anti-tuberculous drug, these drugs have been historically linked to RBC abnormalities leading to RBC aplasia. In certain disorders, there can be antibodies to the erythropoietin, certain immunological problems, and this can also lead to problems with RBCs. Generally, this RBC aplasia is self-limiting. It goes away in a period of a couple of weeks. But if we have certain underlying pathologies which have secondarily led to this problem, then it is important to address those issues and manage the primary disease, and that takes care of the RBC aplasia on itself. Finally, let's look at a differential diagnosis of RBC aplasia. If we have RBC problem, what can be the other types of disorders that can present with RBC aplasia? Different types of anemias can have the same picture, and we have to evaluate the patient on the basis of the other signs and symptoms. Reticulocytopenia can be there, and this needs to be differentiated from a pure RBC aplasia. Then there can be a low erythroid precursor cells because of any bone marrow abnormality, and then we have to differentiate that this erythrocyte precursor cell problem is either pure red cell aplasia or certain other hematological problem. And finally, a rare syndrome, a diamond black fan anemia, which presents in infants with anemia, can also be listed under the differential diagnosis of pure red cell aplasia. Erythroblastopenia, in which the erythroblasts, which are the immature blast cells of the erythroid lineage, when their count is low, it also needs to be differentiated from the pure red cell aplasia. So these are certain types of different disorders which we have to keep in mind while evaluating patients with decreased types of erythroid precursor cells, that either it is a pure red cell aplasia or it is one of these disorders. And we perform the various investigations too, and look at the patient's picture on the whole to finally arrive at a definitive diagnosis. What are the important clinical features the patient will present with, and what are the various secondary diseases? The clinical picture will be basically predominated by the primary disease. For example, if someone has a thymoma, then that will be the initial presenting complaint, and then the pure red cell aplasia or PRCA can be a secondary finding. Similarly, certain types of problems like the granular lymphocytosis or in the malignancies like CLL or chronic lymphocytic leukemia, these patients can have a hemolytic episode with RBC aplasia because they are having problems with hematological system. So any problem with the hematological system, either a hemolytic anemia or different types of cancers, in fact, involving the either primarily involving the bone marrow or because of secondary metastasis to the bone marrow, they can have an RBC aplasia episode, which is self-limited generally and goes away in a couple of weeks. And certain types of hypoglycemia, like the IgM or IgG disorders, the immunological disorders, they can also complicate the disease and present with these clinical features. One important thing to talk about is when we have a persistent parvovirus B19 infection, then there are certain types of cells like the pro-normoblasts. As you can see, these large enlarged cells, these are the pro-normoblasts. These are pathognomonic of this persistent B19 infection, and they will be present in the peripheral, in the bone marrow smear. These can also be seen in the other types of cells, like here it is a collection of these pro-normoblasts. Here you can see certain types of sideroblasts. If sideroblastic anemia, generally whenever there is a chronic infection, as we know that the body tries to conserve iron, so there can be a sideroblastic anemic presentation as well in these patients. So pro-normoblasts are important to remember when we are talking about a persistent parvovirus B19 infection. Let's talk about the treatment options we have. It is important to treat the primary disease. It can be done with the help of certain radiographic procedures. If we have a mass, we can remove it. Surgery can be done for example, removal of a thymoma. Immunosuppressive therapy with various types of immunosuppressive agents can be tried. Supportive care, if the patient has infections, we might give antibiotics. We might have to transfuse the patient if there is a low HP or the hemoglobin count. A combination of erythrocyte transfusion and iron chelation is also very important to avoid the iron overload. IV IgG can be tried if there are antibodies to the RBC's erythroid precursors, and the general dose is 0.4 grams per kilogram daily for about 5 days, and it generally takes care of the problem. Other types of immunosuppressants like glucocorticoids or the anti-cancer drugs like cyclosporin, they can be used, and like in aplastic anemia, we can use the ATG or the anti-horse thymoglobulin. So the treatment options generally are basically the same as were evident for aplastic anemia. And this pure red cell aplasia can be basically thought of as a spectrum of a disease. It can lead to aplastic anemia as well, and it can be a mild representation of aplastic anemia. As a thiopurine is another drug along with the cyclophosphamide. So generally, our treatment options are, if we have a mass, remove it surgically or radiographically. Immunosuppressive therapy can be tried in young patients. Supportive care can be given. IVIG can be used if we have antibodies. And most of the patients, they do not require this and immunosuppressive therapy, because when you treat the primary problem, the RBC aplasia generally goes away on its own, and you generally have to manage supportively the patient. For example, give them antibiotics if they have certain infections, or transfuse them if they have a very low hemoglobin count. So with that, we complete our discussion of the bone marrow disorders, the bone marrow syndromes. This is the first part in which we talked about the aplastic anemias and the pure red cell aplasia. And in the next part of this lecture on bone marrow failure syndromes, we're going to talk about the myelodysplastic syndromes and the myelophysis. Thank you for watching sqadia.com.